Hello, my name is Dr. Monica Flores. I am a pediatrician in South Florida, and I have been in practice since 2001. I'm going to talk to you about evaluation and management guidelines. These guidelines have been changed and revamped and are going to become effective January 1st, 2021. This is my take from a general pediatrician standpoint. I think it can be used in general practice for internal medicine and other generalists, family medicine, etc. I am not a coder. I am a general pediatrician with an interest in coding and an interest in being paid by the insurance company for the job that I do. The information obtained in this presentation came directly from the AMA. I also attended a few coding conferences and tried to assimilate all the information into one PowerPoint presentation that I hope that you will find helpful. First and foremost in coding that has not changed from previously is that we can either continue to code by our medical decision making or we can code by time. We do not have to meet the criteria of time for medical decision making and vice versa. You meet one or the other, whichever one gives you the highest level of service for what is documented in your note. When we code by time, we have to document what was covered in that time that was billed. The biggest change that has happened with coding by time is now we are going to be paid for our total face-to-face and our non-face-to-face time. So all that time that you spend reviewing the chart, the labs, the notes, the consults, the x-ray, the physical time that you spent with the patient, taking the history, the exam, the counseling, ordering the medicines after the patient leaves or the procedures, emailing them, documenting that visit, putting in those referrals, all that time can be accounted for into your visit note. Also, if you in your office are able to independently interpret results, this independently, it comes up over and over again in these new guidelines. And it's very important to note that when they say independently, that means that you are actually looking at the EKG tracing, the chest x-ray, not the report, but the actual film, the MRI, etc. And you are putting your interpretation into the note. If you communicate with other providers that are outside of your practice that day, talk to the nephrologist, the ER doctor, etc., or you coordinate care with others, all that time can be added up together for the total time of your visit. You don't have to currently itemize that time, but most of us don't actually pay attention to the time. So between now and January, start looking at how much time you do spend, see if you could figure out some way in your EMR to account for the time that you review the chart prior and the time that you're in with the patient and the time afterwards. The time that is included is only the provider time, not the staff time, and it must be on the day of service. If you are in the habit of reviewing your charts the day before to look things over, that time will not be included. If you're in the habit of documenting your, finishing your notes the next day, that time will not be included. It has to be the time that's on the day of service. And if more than one provider is involved, then both providers' time can be accounted into one encounter. However, if two or more providers meet to discuss a patient, only the time of one provider is counted. So what does this mean in real terms? In real terms, it means that if you, oh, by the way, a colleague, hey, I have this rash, I think it's this, I think it's that, should I do this? And you just do that either during your lunch hour or in the hall, then that time cannot be accounted for. But if you call in your colleague into the room and you guys discuss it, they look at the rash, you come to a consensus, the two of you, then that time, both your time and the time of the colleague that you called in, can be accounted for in the total time. Again, when we are having staff perform services, that time cannot be accounted for. So if a staff is starting a nebulizer treatment, if staff is teaching them how to use the nebulizer, if staff is performing pulmonary function tests, that time cannot be accounted for. Also, if those services can be separately billed, so the actual pulmonary function tests, the PHQ-9, the ADHD forms, those are billed separately in your note, so that time cannot be billed. But if you have a patient who needs help filling out the forms and you personally stay in the room, clarify questions regarding those forms and spend your time discussing those forms, then that time can be included. These are in the new time charts. So as you can see, established patients and new patients have different time criteria. and there are ranges for time. So, for example, on 99212, which is a range of 10 to 19 minutes for an established patient, but for a new patient, it's 15 to 29 minutes. So now there are set ranges for each of those times. And if you have visits that are prolonged, then you can add a prolonged code time. And so that goes for visits that are over 75 or 55, depending on if it's established or a new patient. So when encoding by time, in the past you had to document greater than 50% of the time spent counseling. That no longer needs to be documented, but you need to document how your time was spent in reviewing the chart, taking care of the patient, and what things were done for the patient that required the time that you are documenting.
In preparation for these changes, I have made cheat sheets for our office so that the providers can be ready for the changes coming up in January 2021.